Uh, Good morning. Actually, I'm what figured out in the administration of the pediatric department. And of course, with the great insistence and opportunity given by our departmental HOD, Dr. Devika Madam, and of course, Dr. Rekha Madam, and all the pediatricians and interns. Though I'm working in medicine department, but emotionally and work-wise, I'm more attached to pediatric people. You know the reason. Sandeep also knows. So this is a very important subject. I'll try to finish and I'll try to justify the subject. And the subject topic even was uh, ITP. That earlier we knew that the ITP means idiopathic thrombocytopenic purpura. But of late, that is absolutely misnomer. There is no more idiopathic. There are not necessarily purpura in this clinical setting. So everywhere in literature in books, it is known as immune thrombocytopenic purpura. So before going to this, so several aspects. Today is the day of the bleeding. From morning, we have started with ma'am regarding the bleeding. So just let me recapitulate my first MBBS and then I will come to the track. So we know that blood, we just got plasma and cells. And these cells are red blood cells, white blood cells, and platelets. Correct. So today we'll be talking more about this coagulation factors, bleeding disorders, platelets, and so forth. So we know that the platelets actually they are produced or derived from the bone marrow. And there are some capillary sinuses in which, under the influence of the thrombopoietin hormone, and this thrombopoietin hormone is actually protein synthesized from the liver, and that gives stimulus to the megakaryocytes to produce platelets. And now the platelets are being formed, they are circulating in the peripheral circulation, and 30% of this circulating platelets, half-life of which is around 5 to 7 days, up to 10 days. Platelets are surviving after being manufactured or produced from this bone marrow. They die on the 10th day. Spleen, only 30% of the sequestration occurs in the spleen, and rest of them in the reticuloendothelial system, Hoover cells of the liver, and other organs of the reticuloendothelial system. And now, what happens actually, these people are going from Manvi to Muscat or Manvi to Somalia. In between there are chachias, on these modes. So these are nothing but the antibodies. And these antibodies prematurely they destroy the platelets. Right? So this is how the whole mechanism that the production, either problem with production, either problem with early sequestration due to hypersplenism, or because of some antibodies formation which are targeting to the circulating platelets, and so the platelet function is disturbed and there occurs immune thrombocytopenia. So that's how let us start with this subject of this ITP. ITP is not idiopathic, it is always immune thrombocytopenia. So that is a very brief introduction. Terminology, pathogenesis, epidemiology, clinical features, laboratory diagnosis, evaluation, diagnosis, and treatment. Now, we knew that the ITP or immune thrombocytopenic purpura was previously known as idiopathic thrombocytopenic purpura or immune thrombocytopenic. Current terminology, immune thrombocytopenic. No purpura because in most of the cases we do not see purpura. ITP of the childhood will definitely discuss regarding some portion of the childhood also, where there may be an isolated thrombocytopenia. There can be only an isolated thrombocytopenia, nothing else. So where the platelet count may be less than 1 lakh. Normal platelet counts are 1,50,000 to 4,50,000. But if platelet counts are less than 1 lakh per microliter with normal WBC and hemoglobin, then we can tend, or we can say it in the case of an isolated thrombocytopenia in children. Primary ITP, that is in the absence of other causes. We have done extensive investigation. Now, all these extensive investigations, evaluation, and workup, we don't see any case responsible for the ITP. There is no primary ITP. In the absence of the other causes, the main focus of this presentation, that is primary ITP, which is categorized into the 3 phases depending on the duration of the disease course. That is the newly diagnosed ITP, where the ITP occurs within 3 months of the diagnosis. That is newly diagnosed. Persistent ITP, ongoing ITP between 3 to 12 months from the initial diagnosis, and chronic ITP, which is seen in adult, where the ITP is lasting for more than 12 months. So we have got 3 phases: newly diagnosed within 3 months, persistent 3 to 12 months from the diagnosis, and chronic means more than 12 months. The clinical features are more similar. ITP starts with this minor bruising, and then where the platelet count will be normal, which doesn't require treatment at all, observation only. Only if the mucosal bleeding, GI bleeding, and very similar in newly diagnosed persistent chronic. Secondary ITP, where the ITP because of other causes. So pathogenesis, there are autoantibodies, usually IgG, they are directed against the platelet membrane antigens. Same antibodies which can also inhibit platelet production. In some patients, now for this, I would like to have some our physicians friends and even in UG medicine teaching, that the aspirin is considered as cyclooxygenase enzyme inhibitors. Aspirin is considered as cyclooxygenase enzyme inhibitors. You know that the platelets are very important for stopping the bleeding, right? By the various mechanisms. And at the same time, platelets are also important as per the fluid dynamics to keep the fluid in a fluid manner, because from the arachidonic acid, prostaglandins are produced. And this prostaglandin, PGF2 alpha, they are the vasodilators. And there are some nitric oxide, they are also vasodilators. So they will try to keep the blood in a fluid manner, means so that there should not be platelet aggregation. And whereas the PGI2, prostacyclin, and there are some vasoconstrictors also, they will try to activate the platelet and they will produce thrombosis, slowness of the blood, and sluggish flow. So this sluggish flow is again because of the activation of the endothelin and other factors and prostaglandins. There is always a dynamic equilibrium or balance between two. There are the vasodilators, there is platelet inhibition, and platelet activators. And so the platelets are remaining in the blood it keeps the blood in a fluid manner so that the blood flows smoothly. Now, if the platelet activators are activated, then there will be thrombogenic attitude. And if this dilates the platelet inhibition, then there is thrombocytopenia. So that is important because many times we know that the problem with this cerebral circulation, coronary circulation, peripheral artery circulation, here there is problem. So that is very important part of the platelets. So now we are talking about the O2 antibodies, circulating platelets, where the O2 antibodies usually IgG, they are directed platelet membrane antigens, the same antibodies which may inhibit the platelet production from the bone marrow, factory bone marrow production. In some patients with ITP, an alternative immunologic mechanism of the T cell, basically there are 2 types of immunity. One is the cellular mediated T cell, and humoral, that is T-cell mediated immunity. So, in some patients, alternative immunologic mechanism of the T-cell, cellular mediated cytotoxicity, which may cause thrombocytopenia, and these cytotoxic T-cells, killer cells, which may act upon the megakaryocytes, that is the main cells to produce platelets in bone marrow rather than circulating platelets. So this cellular immunity directly involves on this bone marrow megakaryocytes. Epidemiology, annual incidence of the IT is estimated to be around 1 to 6.4 cases per 1 lakh children present at any age, but there is a peak incidence between 2 to 5 years in children. There is a slight predominance of the boys to girls, especially infants, 1.7:1. In children, boys, whereas in adulthood, females are affected in adulthood. In children, boys are affected more, 1.7:1. There is a female predominance in adolescents and younger adults. Seasonal fluctuations have also been reported in spring and some early summer. This season is going on. So one should not surprise to see the case of ITP. One should not do anything. Observation, observation, observation. There is no aggressive treatment unless there is previous intracranial hemorrhage or cranial hemorrhage. Otherwise, we can watch. An association with allergic diseases, it has also been reported because of the skin manifestations also during this season. Clinical features, ITP is always immune thrombocytopenic purpura, typically present with sudden appearance of the petechial rash, bruising, and or bleeding in otherwise healthy child. All of a sudden, parents will say, my child has got bruising, chakama padi gaya chhe. Yes, lal chakma padi gaya chhe. Lana nahi gaya chhe. So, the pedigree, they are the smaller lesions, whereas the purpuras, they are larger lesions in diagnosis. ITP is occasionally detected incidentally without any clinical manifestation when doing CBC for other reasons. After the patient died, OPD. After Alta Chalta, reflexly, CBC, Sandia say, even Kagi, so, very government say, incidentally, ITP is occasionally detected incidentally without any clinical manifestations. As doing routine CBC. Bleeding symptoms. Grading of the severity of the bleeding symptoms in children with immune thrombocytopenia. Grade 1. What is grade 1? That is minor. Very minimal. Few petechi, less than 100 totally, and or less than or equal to 5 small bruises, and less than or equal to 3 centimeters diameter. Very small. Mild bleeding. Considered mild. What to do? Grade 1? Nothing. That's all. Grade 2, grade 1 is minor or minimal, grade 2 is mild. But there may be many petechi, more than 100 total in the body, and or more than 5 large bruises, more than 3 centimeters in diameter. It is mild or grade 2. Grade 3, moderate. Mucosal bleeding. There may be bleeding from the nostril, wet purpura, that is known as wet purpura, that does not require immediate medical attention, supervision, such as brief episodes, intermittent blood bleeding. These parents are very anxious. They say, doctor, so, question. Parents are concerned, but again, we can go. Even in moderate mucosal bleeding, you can give this next acid and other treatment and taking and all. But don't react aggressively, that's point. Grade 4, severe mucosal bleeding or suspected internal hemorrhage, like peritoneum, retinal, intracranial, that requires, of course, immediate medical attention, like severe GI bleeding, hematemesis, melena, severe prolonged epistaxis for more than 15 minutes. And not by the 15 minutes of Verdo Kala, in Bharat Nico, Jara Piasan, for Maba Pantan Kasi. 7,000 Jara, and they were the Pantan. Exaggerate perceivable. Mucosal bleeding or suspected internal hemorrhage that requires immediate medical attention in case of severe GI bleeding, severe prolonged epistaxis more than 15 minutes, pulmonary hemorrhage, hemoptysis, or blood in the sputum, and muscle or joint hemorrhage or vein arteriosis coming on. So, where we, of course, we have to admit the patient only in this case, grade 4. And life-threatening shocks state where documented intracranial hemorrhage, life-threatening or fatal hemorrhage in any site where hemodynamically pulse the BP goes down, in such cases, definitely we will treat aggressively. So these are the severity of bleeding of this bleeding symptoms in children with ITP, grade 1 minor to mild, grade 3 moderate, not to worry, and from grade 4 onwards, you have to attend and you have to do the needful guideline directed medical treatment. Nowadays, there is a concept known as GEMT, that is guideline directed medical treatment. It is not just a good treatment or it is not XYZ treatment. It is guideline directed. You have to go as per the guidelines, GEMT. So, site of the bleeding now, in a large registry study of the children with newly diagnosed ITP, following bleeding manifestations that reported cutaneous skin, fatigue, purpura bruising in 86% of the cases in ITP, nasal 20%, oral 19%, no bleeding at all in 9%, menstrual menorrhagia, gastrointestinal urinary hematuria less than 3%. You should ask history. We are still talking about the children. So the sites of the bleeding, skin, nostrils, oral, and so on and menstrual. Serious hemorrhage. Risk factor for the serious bleeding includes severe thrombocytopenia with less than 20,000 per microliter. These are the risk factors for the serious bleeding. Previous minor bleeding. Earlier, there is history of the bleeding. And chronic ITP, when the symptoms are for more than 12 minutes. Epistaxis lasting for more than 5 to 15 minutes duration, give attention. Gastrointestinal bleeding, other severe mucosal bleeding requiring hospital admission and blood transfusion, and intracranial hemorrhage, of course, diagnosed by CT scan or MRI, only less than 1%. So, these are these clinical situations where there is a serious hemorrhage that we should very much be sincere enough regarding this, the type of the bleeding and the duration as well. So what are the laboratory findings? As we know, it is pertaining to platelets. So platelet counts ideally should be 250,000, 450,000, and the age advances. You must have seen senile purpura after the age of 60 years. There is a table that platelets will pour physiologically. And at the age of 80, you should not surprise to see the platelet of 2 lakh. One should not surprise. It is a normal for 10. So platelet count of less than 1 lakh now it is an alarming sign, and other CBC findings are generally normal. Peripheral blood smear, expert PS, platelets are usually decreased in number in peripheral smear examination, normal in size, and variably sized with larger platelets, particularly when the symptoms have been present for several days. Larger platelets, that is most important thing. In case of, always think of the large platelets in PS. If the size of the platelets are more, then this means that ongoing ITP. Bone marrow examination. Now, bone marrow examination can be done by bone marrow aspiration to sternum through this iliac crest, and also people are doing from the tibia, either bone marrow aspiration or bone marrow refined biopsy. So, whatever bone marrow examination, either aspirate or biopsy, is not necessary for the greater majority of it. No. And it is performed only in selected patients to exclude the other causes of thrombocytopenia, such as malignancy or myelosuppression, aplastic anemia, myelodysplastic syndrome, leukemic infiltration, and other hematological disorders. So, immediately, just for the sake of writing down the list, फटाफट मोकलाइ आपके पास पेशेंट आ गए, पल्स बीपी नहीं चुका, सीधा दवा दो, इकोकार्डियोग्राफी कराएंगे दो, एमआरआई कराएंगे, सीधी कहीं दर्दी ने जो तो करा, दर्दी तो आपको चाल तो बराबर है. So even in this situation, bone marrow examination should be done very late. If there is a clear-cut case of isolated thrombocytopenia, no need. You got examine information from peripheral blood smear. Indication for bone marrow. So, bone marrow examination can be when atypical clinical or laboratory features are present. If you find some atypical clinical presentation or some in peripheral smear, some abnormalities, then think of bone marrow examination. Insufficient to or no response to conventional treatment like glucocorticoids, IVIG, NPD immunoglobulin, relapse, failure of the treatment. Think of bone marrow examination. New findings that emerge during follow-up.
loss of response to typical ITP therapies that had previously been effective, now it is not effective. Glucocorticoids earlier effective, Vancomycin now no. IVIG effective now no. NDE effective now no. No response. Rituximab effective now, not response. Then wait for this bone marrow examination. Evaluation, initial laboratory testing includes complete CBC, platelet, WBC, RBC, retic count, peripheral blood smear, blood type, direct antiglobulin test. Now, earlier it is known as Coombs test, that is direct antiglobulin test to be also performed because of the Ewald syndrome. What is Ewald syndrome? There is autoimmune hemolytic anemia with IPT, that is Ewald syndrome. So, we will do this DAT, direct antiglobulin test. Diagnosis. ITP is a diagnosis of exclusion. Your extensive investigation, PUO or FUO, pyrexia of unknown origin. Halta jalta FUO location, FUO, no way. Ila bhai tapas karani છે. Fever part bhai tapas karani છે. એ બધી તપાસ કરાયા પછી પણ કારણ ન બનતું હોય એટલે એમ કહેવામાં આવે છે કે તાવ માટે એક્સપ્લોરેટરી લેબોરેટરી પણ કરવી પડે છે for the diagnosis of the cause of fever. Even people were doing exploratory laboratory work to investigate for a cause of fever. Yes, it is written in books. The point of discussion is after ruling out almost all the possibilities responsible for ITP, then it is diagnosed by exclusion. You rule out other causes of thrombocytopenia. And for the children with a typical presentation of the ITP, presumptive diagnosis may be established based on the following criteria. I'm talking more on the children because of pediatric population. And in children, not to worry at all. There is a movie by Ram Gopal Verma, Darna Jaruri, Darna. बाद में थोड़ा डेवलपमेंट करना पड़ना है। हमारे पास पेशेंट आते हैं ASD, ESD, PDA, यूएस में था यूएस अरे भाई क्या यूएस में था 3 महीने के बाद आउट से बंद हो जाता है। Likewise, in children also, following infections, there is ITP, mild using, mild bleeding or not at all, and automatically infection become alright without treatment. So we can watch an observation. Observation, you should have always good convincing all the parents and relatives खास करेंगे। इन अमुक relatives अमेरिका की आया है, अमुक मुंबई की आया है, प्रभाव पड़ा हमारे तुमने दमपाल, साथ में नाम आपी लेंगे, बेम आपी दी, इन साइड में जैसा दिखता है। बराबर, parents जुड़े बात करो, क्रम में नपशिया उनको पढ़ो। बराबर, in short, ITP is a diagnosis of exclusion, and in children, so following we have to adhere to the following criteria. Platelet counts less than 1 lakh, not to worry. Otherwise, normal WBC with differential count, hemoglobin and retic count. No abnormalities on peripheral blood smear after reviewing by an experienced practitioner. Experienced practitioner means so PS mark. हमारे lab technician था, ये શું કરતા હતા એના લેન્સ ઉપર ફાંસી પેરમના લાગેલા હતા એ સાપ બધાને ફાંસી પેરમનો રિપોર્ટ આપ્યો ઓકે એ લેન્સ સાફ નતા કરતા એ જોઈ સાહેબ સલ્ફર ક્લોરીન પછી કોઈ કે ભાઈ તમે તમારો સાફ કરો લેન્સ એમાં ફાંસી પેરમ ચોટેલા છે. So it should be done by the experienced one. So it's peripheral blood smear should be reviewed by an experienced practitioner. Negative direct antiglobulin test, relax for autoimmune hemolytic anemia and ITP. If it is Coombs test or negative direct antiglobulin test. Absence of associated conditions that may cause thrombocytopenia. There are several associated conditions: rheumatoid, HIV, SCV, SLE, so on and so forth. So these conditions, after ruling out that those other conditions responsible for thrombocytopenia, finding that suggests a diagnosis other than ITP. Please stop me. Finding that such a diagnosis other than ITP, then there are some enlargement of lymph nodes, liver and spleen, systemic symptoms because of fever, anorexia, bone pain, joint pain, weight loss, or hemothrombocytopenia, thrombocytopenia. You may get long-standing history of atypical bleeding and the presence of the clinically significant systemic diseases also we should search for. What are the treatment options in ITP? Childhood ITP is usually acute and very much self-limited. Acute, lasting for maximum 4 to 6 days, even very rarely weeks. So, childhood ITP self-limited with 75 to 80% children having complete remission within 6 months. It is maximum period they have shown. The chikungunya દર્દીઓ હોય છે, it is a હાથ અને પગ વળી ગયા છે. The Swahili word here. Chicken, it is nothing to do with chicken or nothing to do with Bhuvan. हमारे Bhuvan नाम નો પટાવાળો છે. કે Bhuvan chicken ખાતો તો રોગ થયો નામ chicken બોલી આવે. એવું નથી. It is a Swahili word. In 1952 in Africa, the people started moving like this. That is chikungunya. Where this residual arthritis lasts for 6 months. So here also, 6 months in all the cases, no. Very rarely, usually some days to weeks. Self-limited 75-80% of the children with ITP, complete remission within 6 months. Close observation is often the only therapy needed because ITP is a self-limiting condition. The serious bleeding is rare even with low counts. Trick of the trade. Sorry to those who are sitting in the private, the big corporate. Ram Gopal Verma નું બીજું વાક્ય બોલશે ડરના જરૂરી આપણી પાસે આવે ડરના મનાય આપણે એમાં માનવાનું છે એટલે દર્દીને કહેવાનું કે ચિંતા ન કરો 100% મટી જશે આટલું બધું થાય આટલા બધા ડોક્ટરો ભલે કે તમને જાણવાનો વિશ્વાસ છે મટી જશે. Medical treatment is often considered patient with a platelet count of less than 10,000 or those with old glucose bleeding. It should be 10,000. Even Harrison said up to 5,000. Don't worry up to 5,000. Sir, platelet treat करे थे डेंगी नहीं होता. Senior IAS IPS officer को खपड़ा हुए थे निचोड़ी से क्या सर ड्यू रिस्पेक्ट सिविल काम कि भाई अगला प्लेटलेट डॉक्टर सर तुम करता है कि नहीं ऐसा तुम्हारे प्लेटलेट साझा करो लेकिन दर्दी ने साझा करो. We are not treating the report, we are treating the person as a whole. So people will always say, "Is that 10,000 થઈ હવે કાઈ કરો હવે કાઈ કરો." પણ બાપા શું કરીએ એટલે કે ખાતું તો છે નહીં તમે ગોદડું લઈને સુઈ જાઓ કાઈ નથી થવાનું. Medical treatment is often considered only and only if it is 10,000 in this that too. Listen, it is 5,000. Don't worry, up to 5,000. For sure that's wrong. Additional reasons to use pharmacological therapies to raise the platelet counts more rapidly in patients with participant high risk activities are coming invasive procedures. Of course, those who are going for dental procedures, those who are going for surgeries, XYZ procedures, then of course we have to think for this platelet. There are chances of bleeding during surgeries and minor procedures. We have to consider medical treatment. Treatment involves preventive life-threatening bleeding, intracranial hemorrhage, GI bleeding, retinal hemorrhages. Maintain the safe platelet count more than 30 to 50,000. Pregnancy 50,000 as per the guidelines. It should be more than 50,000 during pregnancy. Sanket, am I right? Sanket is a master. Avoid over treatment. He is from Rishikesh. Avoid the over treatment. Karana udani vadharani treatment na apni. Minimize the drug source because drug interactions are also there and improve the quality of the life. દર્દીને કહેવાનું બીજું કઈ કરો કે ન કરો. સાચી સલાહ કે તમારું જે બ્રશ છે ને બ્રશ એ સોફ્ટ વાપરો. બની શકે આંગળીથી બ્રશ કરો. બ્રશને કારણે પણ ટ્રોમા થાય છે. એને એ ખબર છે બ્રશ વિગ્રસથી પકડો સવારના પોરમાં. એકદમ મોઢું ઉઠે અને ભયંકર પકડો આગલા દિવસે ડિપ્રેશન અને ફ્રસ્ટ્રેશન બ્રશ લાગે એટલે બ્લીડિંગ થાય. એટલે ભાઈ ટ્રોમાને કારણે થયું એક્ટિવિટી કારણે થયું. Even more the lifestyle modifications. So prevent the life-threatening bleeding that doctors will decide. Patient cannot maintain the safe platelet count 30,000, 50,000. Avoid poor treatment. વધારે પડતી ટ્રીટમેન્ટ કરવાની જરૂર નથી ભાઈ. IVIG નો ડોઝ હોય હજી બધી 10 કિલો આપી દી એમ ન હોય. જે આપવા ગાઈડલાઇન્સ શું છે minimize the drug toxicity. Drugs are very much toxic. Improve the quality of life. And you can see the algorithm. I have seen yesterday algorithm of ABCD. From lot of drugs in clinical practice, they are producing thrombocytopenia. From epciximab, acetaminophen, lot of antibiotics, aspirin, clopidogrel. Therefore, the studies of the people antiplatelet agent clopidogrel is recommended only up to 18 months following angioplasty because they produce thrombocytopenia. So there are several drugs, also drug-drug interactions. So now when to treat? When the platelets are more than 30,000, no bleeding, observe. Don't worry. Less than 30,000, mild bleeding, nasal, bruises, fatigue, first line therapy, whatever you decided, like corticosteroids, start corticosteroids in proper dosage schedules. Any count, don't make the count, but major bleeding, there will be hematoma, bleed. That can be retinal, GI, then emergency treatment patients should be admitted to and platelet transfusion. The Pina Saga case, VIPs. રાજકારણી માણસો જે લોકો ડોક્ટર નથી એવા સૌને પ્લેટલેટ ટ્રાન્સફ્યુઝન આપો, સૌને પ્લાઝમા એક્સચેન્જ આપો, સૌને ક્યાંકથી વાંચીએ ગૂગલમાં કે અરે બાપા એ પ્લેટલેટની અસર જ થોડા કલાકો સુધી રહેવાની છે પણ એની જરૂર છે બહુ ઠીક છે. So only in emergency treatment with whether with count any count start emergency treatment, right? So 30,000 is cut line. Corticosteroid main treatment, I will finish as early as possible, maximum 2 weeks. Treatment is very important. Glucocorticoids or corticosteroid, prednisolone 1 milligram per kilogram body weight per day, 2 to 4 weeks. It should be in tapering manner. Response in most of the cases, it is 60 to 80% steroid response in IEP. Dexamethasone high dose, we have got 0.5 milligram tablet. See here, high dose 40 milligram per day for 4 days. Faster platelet rise. High dose of the dexamethasone I have given during my GCRI training at Ahmedabad. I did my training in BJMC similar thing during cancer hospital or contact by Isha with the director of medical. I got an opportunity to treat with high dose dexamethasone. IV immunoglobulin 1 gram per kilogram per day since 1 to 2 days. Response within 24 to 48 hours. આપણે લખશું ઈમેલ કરશું, લક્ષિત સંગીને કરશું, પછી એસ પર હેરાનગી કરશું, બરોબર છે, પણ પછી સતત ચાલુ હશે IV. નો short term effect 2 to 4 weeks. IV IG immunoglobulins. Indications for IV IG severe bleeding, pre-operative, there are chances of bleeding during surgery and pregnancy. These are the 3 important indications for giving IVIG in ITP. Anti-D immunoglobulin for Rh positive patients, non-splenectomized patients, 50 to 75 microgram per kilogram IV causes mild hemolysis and avoid in anemia. That is anti-D immunoglobulin can be given emergency treatment. Intracranial bleed, GI bleeding platelets less than 10,000. Recent Harrison 22nd less than 5,000. Treatment combination IV methyl prednisolone 1 gram IV for 3 days, IV IG, platelet transfusion, tranexamic acid supporting treatment in emergency management of the severe bleeding as we have shown here in that study. Second line treatment, first line treatment completed. Corticosteroid, IVIG and NDD. Now second line, they are failed. Platelets are again decreasing. The person has become earlier steroids responsive, now it becomes steroid dependent. Relapse cases, chronic ITP for more than 12 months, what to do? Historical around 60 to 70% long-term remission delay for more than 12 months post vaccination in splenectomy. Now spleen, spleen is very important organ because 30% of the circulating platelets, they are being sequestrated by spleen. So splenectomy offers very good result in ITP. That it is a historical gold standard method. 60 to 70% of the patients are going for the long-term remission, and if delay more than 12 months is possible, that's but at the same time there are chances of the infection. So vaccination for S. streptococcus pneumoniae, H. influenza, Neisseria meningitis risk. Because of after the splenectomy, there are chances of the infection and thrombosis. One more word for splenectomized patients. During surgery, surgeon like me may drop some splenic tissue inside the pericardial cavity. We do not know about the ectopic spleen, accessory spleen. What will happen after the splenectomy? We'll be happy. See, the platelet count will rise. It may not rise. And again, there will be thrombocytopenia. Because of this accessory spleen or dropped out fine tiny tissues of the spleen during surgery. So that will produce hypersplenism and sequestration of the platelets. And for that, we need to see Howell-Jolly antibodies in platelets. If you see good PS person, pathologist, Howell-Jolly antibodies, think of the ectopic or accessory spleen, right? So that is also a word of this very important word for following the splenectomy. Rituximab, it is an anti-CD20 monoclonal antibody. 375 milligram per square meter weekly for the 4 weeks or 1 gram on day 1 and 15. 50 to 60% response, long-term remission is 25%. Very wonderful drug. TPO, that is thrombopoietin receptor agonist. After CKD patient, erythropoietin appears. From the juxtaglomerular apparatus, erythropoietin is secreted. So in CKD patients, we are giving erythropoietin. And this is a hormone. which gives stimulus from the megakaryocytes. So production will increase with this TPO-RA, that is thrombopoietin receptor agonist mechanism. It stimulates the megakaryocytes of bone marrow, increase the platelet production used in chronic refractory ITP. Other drugs, eltrombopag, romiflostin, and avotrombopag. These are the newer drugs in newer therapies like FOSTA, SYAK inhibitors, reducing platelet destruction, side effect hypertension, diarrhea, FcRn inhibitors, energy, and BTK inhibitors, vilsarglutinib, under the trial mechanism inhibits the B cell and Fc receptor signaling. ITP in pregnancy, preferred drug is prednisolone IVIG, targeted platelets, vaginal delivery. It should be performed more than 50,000. If LSCS, then platelets should be more than 80,000. Secondary ITP with SLE, H. pylori infection, many times associated. So treatment of this concerned disease, underlying disease, a response to treatment, complete if platelet more than 1 lakh, and no response less than 30,000. Complications of therapy, steroid toxicity. We know the steroid toxicity mainly is osteoporosis, diabetes mellitus, acute gastritis. Rituximab, reactivation of the hepatitis B virus, and a thrombopoietin receptor agonist, that is thrombosis, that is again complications. Splenectomy, again infection. Future direction, personalized therapy, tailor-made therapy. You have to give personalized therapy. History taking is very important, and other factors. Combination of the regimens, biomarkers guided treatment, expanding FcRn factors, and so on and so forth. Thank you very much for getting this.